Good afternoon. I'm Paul Irwin. I'm Dean of the School of Public Health at UAB, and I want to welcome you to our panel, Medical Careers in Public Health Practice. We have an excellent panel featuring some of Alabama's leaders in public health joining us today. And I know we also have a large audience logged on right now, excited to hear from them. Today's event is designed to be a discussion. So we will start by hearing from each panelist as they tell us about their career path and experiences. Then we will move into a Q&A portion for the rest of our time. We received several submissions of questions ahead of time that I'll be asking our panelists. So let's get started. Going in alphabetical order. Let's hear from Dr. Scott Harris first, who is our State Health Officer. Dr. Harris, welcome, and give us a few minutes on your path to becoming the State Health Officer.
Sure. Thanks very much, Paul. I've had a lot of chance to reconsider that decision over the past year and a half, but it's really good to be with you. I so much enjoy talking to all of you in the School of Public Health. You guys have meant so much to me personally, and I've really appreciated the professional association we've had, and also just the personal relationship that we've had. I'm a native of Alabama. I grew up in a town in East Alabama called Talladega, Alabama. My mom actually was a nurse and worked for public health. And so I had, even as a kid, some sense of what the county health department was. It was the health department was where we all went to get our shots so we could go to school. There were, a lot of other functions there, but I knew a little bit about public health long before I knew that I had any type of career aspirations that way. But I went to medical school in Birmingham and trained there in internal medicine and in infectious diseases. I did an internship and residency at Caraway Hospital when it was still there, and then did my ID fellowship at UAB. And then went into a career in private practice in North Alabama and in the city of Decatur. So I was there for a little over 20 years doing private practice infectious diseases. A lot of my practice was HIV work, and that was just a reflection of the time that I went to medical school and what I learned as a trainee. AIDS had really just been described, very recently when I was in medical school, and HIV treatment was really starting to emerge at the time that I was in fellowship, and I found that to be a really fulfilling type of work and something that I wanted to continue doing. And so, in doing that, I found that I would overlapped quite a bit with folks in public health as well. I was able to help them manage HIV patients that they encountered. I did work with their TB, tuberculosis patients with STD, but just over time developed really good working relationships with public health. I'll say the other thing that gradually dawned on me as a fairly naive guy from Alabama. Long before I ever heard the phrase social determinants of health, I think I came to realize what that concept meant, and that just came from working in a medical field, dealing with people every single day. It really became clear that disease isn't spread, it isn't distributed evenly among the population. I began to realize the importance of race and income and education and geographic location in terms of how that played into people's path in life, and how it affected their susceptibility to disease, and how it affected whether they did well or did poorly. And over time, that's something that came to mean a lot to me. It was something that I was very interested in trying to understand. I worked for many years for a free clinic that was established in our community because that work was very meaningful to me and helped me to learn a lot about my community and about a lot of the people who lived there. But eventually it became clear to me that public health was actually probably the right place for me, and probably had been all along. It just took me a roundabout path, a long time to get there. But in about 2015, I talked to the then state health officer, Dr. Don Williamson, about a position, and was actually hired in North Alabama as a district or what we then called area health officer. So I had the responsibility for about 7 counties in North Alabama. That was, to be honest with you, the job I think I had always wanted. That was a terrifically enjoyable work for me. But after being there for a couple of years, there was a vacancy in this position here, and I ended up interviewing with the State Committee of Public Health, the governing body of public health, and this position was offered to me. So that's how I got here. I would have to say that one thing that I don't want to leave out, one of the most influential things that happened to me during that time actually was going to the UAB School of Public Health as a virtual student and getting my master's in public health degree. That finally put the didactic portion to a lot of the clinical experience I had encountered over the years, and has really colored my view of the world and made a big difference in where I've been able to get to today. So that's kind of it in a nutshell, Dr. Irwin.
Dr. Harris, thank you so much. And disclaimer, I did not pay you for that advertisement, but thank you very much. Thank you so much for all the work that you've led over these past many months of the COVID pandemic. We're going to move right along, and again, continuing to get about 5 minutes from each of our panelists talking about their paths. I'm going to give Dr. Eichhold a moment to catch his breath before turning to him. But let me continue with Dr. David Hicks, who is with the Jefferson County Department of Health. Dr. Hicks.
Yeah, thank you, Dr. Irwin. So my path was a little different as well, I think. So for me, after undergraduate education, I wanted to take a break from going straight to medical school. I was kind of burnt out, and I actually thought I was going to do, I really wanted to do neurosurgery. And I was thinking about getting a master's degree in medical informatics so I can also do some computer programming, software development for potential neurosurgical operations I may do. And, you know, one of the programs I was applying for to get that informatics degree was housed in the School of Public Health at my alma mater, which was in Pittsburgh, Pennsylvania. That's when I really started getting understanding of what public health may or may not be about. So I actually enrolled in the public health school thinking I was gonna get a medical informatics certificate. And this was during in my senior year of college, I took a computer programming class, C++, and I couldn't stand it. And I said, I'm not cut out to be a programmer and do this computer stuff. But then I started falling in love with what I was hearing about public health. So I'm going in public health school, doing behavioral and community health sciences. And I completely changed what I felt I wanted to do in my role in the field of medicine. So I went from wanting to be a surgeon to then shifting to wanting to do primary care and prevention based on my training in the public health school. And I was sitting in here, and one of the things I think other people can tell you about is the field of medicine and public health, although there is relation there, unfortunately, they've been so separated in the curriculum, is that the public health folks will say medicine doesn't understand the big picture, and the medicine folks will say, "Oh, we're the doctors," you know. And so I had a different perspective. So when I went into medical school, knowing I wanted to do prevention, primary care, but trying to figure out how I would use my public health training was to be determined. So I went into family medicine, and then when I graduated out of my residency program, I worked for a traditional hospital system where I was hired by the internal medicine department. I worked for a hospital system, major academic medical center, and I did bread and butter primary care, you know, in another state. And over time, I started to, I'm the kind of person who I have opinions about how things should be done certain ways. And I was frustrated with the people that were in charge because I said, I don't have any control over how this is done or how the clinic is doing this way. And so ultimately I ended up migrating down to Alabama, and I started working for a community health center, a federally qualified health center. And within 7 months of being there, the chief medical officer resigned. The CEO came and asked me, "Hey, you always are having ideas and talking about things. I want to give you a chance at being the medical director." I had no experience. So so when I took that role, I was running 5 clinics, and I had a more affinity to, administrative things than otherwise, but it still was something was missing. So although I was doing primary care in underserved areas, I just felt like something was missing. And when I decided to make a transition, and Dr. Wilson, who's on here, recruited me to come into public health. I had a public health degree, a background and understanding of public health, but wasn't working in the field. And I knew that my next job had to really give more fulfillment. And so when I came into the health department, my first job was the medical director over adult health and family planning clinics. And so I was doing primary care, but then I was able to try to go beyond just the core primary care and look at more community outreach and programs. And then after that, I had the opportunity to, due to a retirement, to apply for my current position. So I'm the deputy health officer. So I'm in charge of all the clinical operations. So as a physician, I'm overseeing all the clinical programs. And so that's the traditional public health things, but then not the traditional primary care things. So we've had adult health clinics, which we no longer have, but adult health, family planning, pediatrics, the pharmacy things that we do that, rolls up to me ultimately. And then in disease control, it's the tuberculosis and travel clinic, and sexual health clinic. So all those program areas and all the directors over those areas, I'm the one who's providing some of the strategic operational guidance there. So that's what I'm currently doing. So my last thing just to say, Dr. Irwin, would be in public health, you can do potentially get primary care or bread and butter work, but then there's the whole public health side where you need physician leadership to help guide some of these projects that happen in public health.
Dr. Hicks, thank you so much. Very, very helpful to hear your path. I'm going to go next to Dr. Bert Eichhold, who is the health officer for Mobile County Health Department. For those of you who may be new to understanding the structure of public health in Alabama, let me just comment real briefly that that Dr. Harris is the state health officer, is over all county health departments throughout the state, primarily for 65 of Alabama's 67 counties. There are 2 counties that have what I would describe as independent metro county health departments that report to county government. And those are the Jefferson County Department of Health here in Birmingham, and the Mobile County Health Department, which Dr. Eichhold leads. I hope I characterized that in the right way. Dr. Eichhold, will you share with us a few minutes about your path?
Yeah, thank you very much. It's a pleasure being with you. My past actually started a little crazier and not as well organized as others who have spoken. Right out of high school, I got plexed with the draft in the Vietnam War. And so my selective service number allowed me to go into military service instead of going to college. A good learning experience. Then I went to undergraduate school at Tulane and decided into my freshman year, I really wanted to go to medical school. At the end of my 4-year program, I was on the waiting list to be accepted to Tulane College of Medicine. So I said, what am I going to do if this doesn't work out as I'd like to? So I applied to the School of Public Health. And while on the waiting list, made a decision that what could separate me from somebody else in September. So I went to Georgetown University, took gross anatomy, did well in that course, and then got accepted to medical school with about 2 weeks before school started. When I told the School of Public Health that I had been accepted to medical school and wouldn't start in School of Public Health, they said I could do both. And I went, wow, I've done a little research. And so Tulane was very aggressive in joint degrees. About 30 or 40% of my classmates got MDs, MPHs, Masters of Science, PhDs, it was really an exciting time, and the School of Public Health was really a very special place. The other thing I learned at Tulane is if you're registered in the School of Medicine, which was a year-long registration, you could take electives in the School of Public Health at no additional cost. So I quickly started signing up and finished my MPH in '78 and went every single summer while I was in medical school in the School of Public Health. I said, this is too good to have, be registered in one school and be able to go to the other. And then finished my MPH in '78, my MD in '79, and then stayed on to do my doctorate of public health, which was in healthcare and correctional facilities. Did a year of preventive medicine residency during that time. Then did 3 years, got my degree in 1980 from my doctor of public health, went to South Alabama in internal medicine, then did a fellowship up at Harvard in diabetes and metabolism at the Deaconess Hospital. And then I went and did flight surgery training in the Naval Air Reserve in Pensacola, then went into private practice. As soon as I got to Mobile, the Mobile County Medical Society selected me to be on the Board of Health. So I did that for 5 years. And then the health officer made a determination he was going to retire, and I applied for the position. So I left internal medicine, endocrine associates, and then was selected in a merit system process and by interview to be the health officer of Mobile County. I left the private practice of medicine where I saw one patient at a time in order to take on a community. And it's really been exciting, wonderful experience. And going through the pandemic, I was at the right place at the right time. And what I learned in the School of Public Health has been tremendous resource to me. And there was one person in my life, Bob Franklin, undergraduate at Harvard, went to medical school on the West Coast, and then came back and decided he was going to have a career in public health. And he was a person who profoundly influenced my life early on during when I was doing the joint degree program at Tulane. And so it's really been an exciting career and a lot of opportunities to do whatever you really want to do. But when I started this, we didn't have a seatbelt law in Alabama. We didn't have a body piercing and tattoo bill. We didn't have a prostitution bill. And in public health, we got involved in all of those, from highway safety to just sanitary conditions, and really had a wonderful, wonderful experience. And I continued to see patients when I came to public health, half a day a week. Still do.
Right. Fantastic. With all of that preparation and training time, Bert, I was going to ask, did you just start working as a health officer last year? But because that's
I've done
lot
this for 31 years, so I've been doing this since 1990. And by the way, Mobile was established in 1702 as a city, and the health department came about in 1816, 3 years before Alabama became a state. And the building I'm located in is actually older than the Statue of Liberty. It was a U.S. Marine Public Health Service hospital, and it's fun to come to work to this grand, beautiful facility providing health care to the community. We're also the only health department in the state that has an FQHC, Federally Qualified Health Center, and public health. So we do both of those missions.
Thank you so much, Dr. Eichhold. Let me turn next to Dr. Mary McIntyre, who is the Alabama Chief Medical Officer. So Dr. McIntyre, tell us about your path.
Well, my path was, again, totally different. And I think that what the takeaway from this will be that we can all you can come in from various ways when it comes down to public health. But the main goal is to have basically a heart to want to make a difference for the population as a whole. I actually grew up in rural North Carolina. I'm the oldest of 4 girls. And in fact, we grew up on a farm. And my father had a 10th grade education. My mom had graduated from high school, but even though she wanted to go further, she was the youngest at 8, and that's not what her father thought she needed to do. So that we basically on the farm, we did all kind of things, but my father came from a family of educators. He just decided to kind of be the one that bucked the system and ran to after the 10th grade because he wasn't allowed to play football, which is what he wanted to do. He took off and went up north. Okay. So, but we were basically raised to make sure that from a standpoint of education, that in order for us to move forward, that's what we were going to have to do, even though he didn't do it. So I did not start out even thinking about becoming a physician. I had watched and with some stuff through the teachers within my school when I was not only just in elementary, but all the way through high school. I had people that actually encouraged me to do more. So my goal was to be a medical technician, a technologist. Okay, that was what I was doing. I actually was offered a full scholarship and partial scholarships to multiple schools as a senior in high school, and ended up going to a little HBCU called Winston-Salem State in North Carolina. From there was a lady that was extremely important in my life. She was the mentor of the program called Project Strengthen. And between her and my husband, who was my fiance in my 3rd year, my junior year, which I actually would have graduated from, they explained to me they thought I could do more than go to school to Meharry and do their medical technology program. So that's how I ended up becoming a physician. Sometimes I wanted to kill my husband during my residency because of that, but we both survived. And we've been married for more than 40 years now. So how did I end up in public health? I ended up with a residency in internal medicine. Ended up in medical school. And by the time I finished medical school, I had 2 children, had another one in my 1st year of residency, and really determined that I didn't really like taking care of people who were dying so much. I spent a lot of time in the CCU and ICU, and really thought there was a better way to handle folks that were coming in with strokes and that were coming in with end-stage renal disease. Okay, so I ended up going in because the only way I could go to school was through the National Health Scholarship Program, which basically put me into the FQHC system. So I worked for 11 years in rural Alabama, and decided that I really wanted to do something more from a policy standpoint. And so I submitted an application to UAB. At this time, they had a school that was on the weekends that was along, I can't remember, Mobile, the coast, somewhere in that area, but found out I was pregnant again. And so I put that back on the back burner again, as far as going to get my MPH. And then decided after my child was able to go, the last one, into the daycare, that it was time to pick it back up. Did my MPH at UAB in healthcare organization and policy, and determined then, because like I said, I saw so much begging, trying to get medicine for people, trying to get people into specialty care when I was in rural Alabama for 11 years, that there had to be a better way, that there had to be a means to try to address the population as a whole. So that's how I went. After I finished my MPH, I was still in rural Alabama. And my husband said, well, I thought you wanted to go work for public health, but you haven't taken a single step to go in that direction. So I put an application in for the state, but the only thing available at the time was in Medicaid. So it was supposed to be a short stop. I ended up at Medicaid as an assistant medical director, then as a medical director and deputy commissioner, working a lot with quality, clinical quality. Actually was over the clinical standards and the QA processes, and trying to improve stuff, and actually put in a system for electronic records statewide, working with Together for Quality. But after 14 years, I thought I had done all I could. And I actually picked up the phone and sent an email and said, to the Dr. Miller and with public health and said, are you all hiring? And that's how I ended up at public health. So it's been wonderful because I took a little detour a little bit longer than I had intended, but I've actually been able to work through with a lot of stuff from the standpoint of policies to get things in place, you know, where we're looking at expedited partner therapy. A lot of things that were not things that were being done in Alabama at the time that I had some knowledge about because I was working at the federal side from the Medicaid program. Even when it came down to things like oral health and the problems that we had with the number of providers, dentists that even participated within Alabama. So that's how I ended up where I am, and I've enjoyed it really tremendously and at the end of my career now when it comes to public health. But that's not the end. The next chapter is working on a faith-based program with the churches in the community, which is what I plan to do. Okay.
Dr. Mack, thank you. Thank you so much. I appreciated your mentioning the work that you did with Medicaid, because what I hope that our audience understands is that there are many non-clinical roles that physicians can play within the public health system. So let me move on to Dr. Mark Wilson, who is the health officer for the Jefferson County Department of Health. Dr. Wilson?
Yeah, I think I'm the only person in this virtual room who does not have a master's of public health. So I'm the flunky. But I had not planned to go in public health. I think that's true of some of us. Originally, I have an undergrad in civil engineering. And while I was in engineering, I always did want to do medicine, but I came from a very pragmatist sort of background where you always had a backup plan. But I was always very interested and very passionate about serving underserved people, low-income people, potentially working in a developing country to serve some of the most destitute. So that was always sort of a driving force for me. I ended up doing internal medicine and came to Birmingham from North Carolina to work at Indigent Healthcare Hospital here with Cooper Green, and spent 20 years there, right out of residency until 10 years ago. And so, again, I really wasn't thinking public health, but for me, I think there was an evolution that occurred over time. I pretty quickly ended up in leadership positions, medical director of the clinics, and eventually was chief of staff at the hospital. And during my last 3 years there, I was asked to come on or elected to the Board of Health for Jefferson County, which is the board of directors for the health department. Little correction, Paul, we are not part of county government.
Okay.
We don't report to the county commission. We have a county commissioner that serves on the Board of Health to represent the county. But our governing board is the Board of Health, which is five physicians and a county commissioner. And I think that's how Mobile is set up as well. And so I guess the one comment about that is that the governance structure for Alabama and for our county health departments is very much physician driven, from the board to the leadership. I'm the health officer, so I'm the head of the health department here. I'm the chief executive, and it has to be a physician that by law. And so for that reason, our health departments, and for other reasons, our health departments have to have physician leadership. It's also because we are involved in clinical work and we use a lot of nurse practitioners, things like that, that require collaborating physicians, physician leaders. But what happened for me is, as I practiced taking care of low-income people, over time, I just began to see the bigger context. Originally, the context of the little healthcare system that I worked in, things that needed improvement to make it a better experience for the people coming into that system for care. But then seeing, some of the social issues and policy issues that affected people's health or made it difficult for people to stay healthy or get treatment that they needed. So I got more and more interested in the larger context as time went on, tried to affect policy change at the hospital, got very interested in healthcare reform on the national level, did some advocacy work there. And then when I came onto the Board of Health, it sort of opened my eyes to even a bigger picture of what the Public Health Department does, which is really quite expansive. We've talked a lot about some of the medical things, but the environmental health part of public health is huge. And our health department here does a lot of community work, a lot of partnership work in the community, to a lot of policy work. But basically what happened with me, I think my fellow board members saw that I was getting more and more engaged in these broader issues of the larger context, the policy issues. And when the previous health officer announced his retirement, it was incumbent on the board to find a new health officer. And some of the people on the board and several other people recommended that I think about that job. And again, it wasn't something that I had thought about, but the more I thought about it, it made sense because it was sort of the direction I was heading. And there were other interviewers, people that were probably better qualified than I on paper, but I think because I knew the community, I cared a lot about the community, especially the underserved, and really wanted to make a difference. I think that's why I got the job. And that's why I really love the job, because it's an amazing opportunity to make a larger impact. The previous health officer once asked me, he was trying to recruit me as a medical director sometime many years before I came here, and I turned him down, but he asked me, which would you rather do? Would you rather give a cup of water to one thirsty person, or would you rather feed the 5,000? And not that any of us are going to pretend to be Jesus, but it was an interesting analogy. And I love both, actually. I love primary care. I love taking care of the individual person. I still do a little volunteer work, so I can enjoy doing that and help some individuals. But it's amazing to be able to be in a position where you can do so much good for a larger population. And here in Jefferson County, we're pretty fortunate to have some extra tax revenue that comes to us that enables us to do more than a lot of health departments do, and to innovate and venture into some new territory. So that's just been really exciting for me. And we do use a lot of physicians here, as Dr. Hicks mentioned earlier, to direct programs that are clinically oriented. But I think it also is just really good that we have physicians in leadership positions, because they do have that broader perspective that I think is very valuable.
Mark, thanks so much. And enrollment in our MPH program is still open. So if you're interested, we can arrange that, and more on that in a few minutes. But I thank you. Thanks to all of you so much. I thought I would also take a couple of minutes and talk about my own path, since I was at one time a public health officer. I grew up thinking I wanted to follow my daddy's footsteps, who was a last of the old country doctors who carried a black bag and made house calls. And so I eventually made my way to medical school, but here at UAB. But in about the third year of medical school, I became disenchanted with what I saw as business taking over medicine, or medicine becoming a business. And so I looked for other paths, other opportunities, and ended up spending most of the final semester of my fourth year on a medical expedition to Nepal. And that's what changed my path forever. The mentor that I took on at that time, who became a lifelong mentor, told me at that point that if I wanted a career at that time in global health, he said I needed two things. first, I needed to have a strong clinical foundation. And so I ended up doing a residency in internal medicine. And the second thing he said was I needed a master's in public health. So I did get my MPH, and then after a couple of years in an international health fellowship in Pakistan, I came back to work with the Tennessee Department of Health, so the counterpart to the Alabama Department of Public Health. And so for most of 16 years, I was a regional health officer over a region of 15 county health departments in East Tennessee, mostly rural Appalachia. And that's where I really learned public health, mostly from great public health nurses who had been doing public health, as they said, all of my life. From there, doing public health practice for many years, I, along the way, picked up a doctorate in public health. And then, as many of my colleagues would say, I went over to the dark side of academia and was at a public health program at the University of Tennessee before coming here to UAB now a little over 3 years ago as dean. So I think what you've heard in these different stories are different paths, different experiences, different ways of getting there. One of the things that I do want to reiterate and will ask Bert, Mark, and Scott to further expand on is that you're not required to have an MPH to be a health officer. It comes in handy. There are things that you pick up as an MPH student that you may not pick up otherwise, or may come to in a different way, but it's not required. We have a number of questions, but I wanted first to ask Scott and Mark and Bert, since each of you have a number of physicians who work under your umbrella, to briefly describe the kinds of positions that are available under your umbrella for physicians. So Mark, let me start with you. I know David Hicks reports to you, but you also have other physicians who report to you as well.
Yeah, we have, well, we do have some clinical operations. Our main two right now are, well, really three are pediatrics. So we do pediatrics primary care. So we have a medical director of pediatrics as well as several pediatricians. So that's just straight medical care that happens to be at a health department. Then we have family planning, which is, federally funded. That requires a medical director. Otherwise, that's run by nurse practitioners, but we have a physician that's over that. And that physician also is leading a new department that we have, which is population health and health equity, which is just a year old here, but we're, and that's really more public health as opposed to healthcare. And then we have our division of disease control, which has a medical director who has also a background in infectious disease. It's not required, but we've often been able to be blessed with people that did have fellowships in infectious disease. So we have a medical director for that, as well as an additional doctor in that area that is a tuberculosis expert, also infectious disease and pulmonary, actually. Pretty blessed to have somebody with that amount of training. That's not a required position here, but it's somebody that we happen to have. I think those are the physician-led areas, and plus the deputy health officer, obviously. We could have deputy health officers who are not physicians, but just for the purpose of succession, it's good to have a person that can easily take over if the health officer gets hit by a truck. Plus here we do have all these clinical type program. So it just works to have a deputy health officer who is over the clinical operations.
Thank you. Thank you, Mark. Scott, what other kinds of positions are there under your umbrella?
Yeah, we have something similar to what Mark just described as well. We have a family planning program, which has a position in OBGYN. We actually have one person wearing a couple of hats in that program right now, but we traditionally would have a second physician in there that takes care of strictly clinical issues, primarily one who serves as the top level administrator that oversees a lot of different things, a lot of different administrative functions. But then we also, as Mark just mentioned, we have nurse practitioners around the state who do a lot of work. And so we have a physician who serves actually as the single collaborating physician for all of our nurse practitioners throughout the state. That's a kind of a special dispensation we've been granted by the nursing board. It's a long, complicated story, but that's a really heavily clinical job. That physician is also in charge of operating what we call a model clinic that's here in Montgomery County, and all of our nurse practitioners come in from time to time. First of all, when they're new hires, but also throughout their career in public health, just to be observed and just to sort of be educated again and observed by the physician who serves as their collaborator. So that's a really heavily clinical role. We have a medical director for disease control as well. That's a job that Dr. Mack herself held at one time before coming to her present job. But that position is charged with overseeing a lot of our disease control programs, which includes our infectious disease and outbreaks team, our tuberculosis program, our STD program, our HIV program. And so all of those are clinical programs, or in many cases, exclusively clinical programs, but we have a medical director who does that as well. We have had other physicians at other times, and we have contracted out some work recently because we've not had full-time people available to do it. But we've had a position in charge of our regulatory programs, particularly our licensure and certification bureau, what we call Health Provider Standards. This is a bureau at Public Health that deals with the licensing and inspection and certification of healthcare facilities, so nursing homes and hospitals, and many different types of outpatient medical facilities. That job does not have to be held by a physician, but it helps a lot. We certify healthcare facilities on behalf of the federal government, on behalf of CMS, and so there's a lot of rules and regulations that are involved if you want to bill Medicare or bill Medicaid. And we get lots and lots of questions and lots of interactions with a medical director in a nursing home or someone working in a hospital on a medical staff about how to be compliant. So that's a really heavily administrative job as well, but one that's very important to us. We have a physician that works with our Office of Emergency Medical Services. We're the state agency that's charged with overseeing and regulating EMS in Alabama, emergency medical services, so ambulances, paramedics, and so on. And so we have a physician that liaises with all the different organizations there in that work. We also, I'm just reminded that we, until recently, actually had a physician who was an international medical graduate who was not licensed to practice medicine in the U.S., but who came to work for us strictly in an epidemiology type role. And so that's someone who can bring a medical perspective, even though they're not actually doing clinical medicine at all. And then finally, I would mention that we do have our area or district health officers, like we've all mentioned before. We actually only have a couple right now. We added our second one just about a month ago. Until recently, we were down to one single area health officer. We're in the process of trying to add new physicians now. Dr. Mack and I have got an interview later today, in fact. So we're trying to add that. But that's the job that I mentioned I started out in. It's in our area, interacting with a lot of public officials, interacting a lot with the public, and doing a lot of education work, doing a lot of work sort of helping out in clinics with those clinical programs, and also the different regulatory functions that happen in the district. So a lot of different variety, a lot of different options. And we're always interested in hearing from people who think they might like to work for ADPH. So.
Fantastic. What a plethora of possibilities. Bert, what do you got down in Mobile County?
Well, we are unique, as we said earlier, as an FQHC. So we have pediatrics, internal medicine, we have OBGYN, we have, all the coverage of primary care. And each one of those areas have a medical director, and then they have physicians who work underneath them. We also have a physician position, which just became vacant in our training department. And then we have a physician position as the medical director, which is also vacant at this time in public health. So being the last one in the boat, I got a paddle. But it's really great fun and good people. So we cover all the primary care specialties in multiple clinic sites around the county. We work closely with the University of South Alabama for any specialty care. We actually have contracts with the university for Ryan White grants. So we provide care for persons with HIV/AIDS. And the infectious disease department, fellows, residents come to the health department and help provide the highest quality clinical care to those individuals within our facility. So we have some specialty care along with the primary care within the health department, but it's really a wonderful experience. And we also have dental care, and Scott, y'all are not dental students, but dental is another big component to the general population, and access to care is extremely important. So we have a dental director also in multiple dental clinics.
Thank you, Bert. So I'm going to turn to a couple of the questions that came up in the Q&A and questions that were posed earlier, and I'll sort of lump a couple of them together, and it's about opportunities. So opportunities either for medical students or opportunities for residents to do electives or internships in the health department setting. So I'll just open that up to anyone who might want to speak briefly about that.
I'll say we certainly welcome that. We wish we could do a lot more of it than we do. Just like every other organization, particularly for the past year and a half, we're trying to do more with less, and we have multiple people doing multiple jobs. So, but we have a long history of bringing people on board who would like to do internships. We have people who come to county health departments sometimes and spend some time there seeing how county operations work. We've had people in many of our other clinical and non-clinical bureaus as well, people in family planning, people in disease control. So whatever your interest is, we certainly would welcome your inquiries, and as capacity allows us, we try to take people as often as we can.
Anyone else want to comment about internship student opportunities, whether they're medical students or residents? Bert? Yeah.
Yeah, we actually have a senior selective at the University of South Alabama College of Medicine in public health. And for a number of years, I was the medical director or the course director for public health and epidemiology in the College of Medicine. So we've had some students through South Alabama, but those educational affiliations, I think, are pretty much standard, that you can go from one medical school selective to another. There's preferential treatment given to the primary academic institution students, but we have not been swamped with applications. We'd love to have people have an experience in public health with us during their senior year.
We haven't had a lot of medical students. We rarely have been able to do that. We do have pediatric residents from UAB Children's who rotate through our pediatrics clinics. And then for public health students, we do have some potential internships. We have some summer intern positions, and then occasionally some special intern positions, depending on if we have a special need or a project we need to get done.
This is Mary, Dr. Mack. We do
Yes, ma'am.
have a medical student one-on-one curriculum. It's really just a week to kind of introduce you to ADPH. That was something that we really needed to try to make happen. That we didn't have anything that was like in concrete, but it is there now, that we can do from the standpoint of introducing people to public health. And then if they want to do something else, then we work with some of the individual bureaus. And that's what Dr. Harris put Ken Harrison in there, that we can actually work through the process with the submission of an application and other stuff that's kind of official. They try to get you into that. We've had to cut back, and I'm gonna say that we did cut back as part of the pandemic, some of that, but we need to get it going again. The whole idea was to make sure, especially with medical students, to introduce them sooner to public health, like during their first couple of years, instead of waiting until they got to the end and then trying to make people aware of what it is that we do. So we can even see in like some of the examples that we had, like with the little weekly schedule that was developed to try to make sure that people were introduced to all the areas. We found out that a lot of folks, especially within schools, not just medical school, but dental school and other areas, didn't really know what we did from public health, and they only needed us. They only realized some of what we did when there was really a problem that was visible. But other than that, they really had no idea of the full reach from environmental and other issues that we are involved in.
Thank you, Dr. Mack. We had a question from Aduke who asked something, and Scott, you alluded to this in your comments. What opportunities are there in public health in the U.S. for foreign trained medical doctors?
We certainly would welcome inquiries about that. Obviously, if you're doing anything that's a clinical service you're providing, you have to be licensed to do that. Healthcare professions that, if you put your hands on another human being, in most cases, you have to be licensed in our society. But we certainly have a lot of work for people who are medically trained but aren't interested or just don't want to do clinical practice. So epidemiology is an area where we can always use people who understand medicine and are medically trained. We certainly have some health policy things that expertise would be very useful in as well. We have an analytics and informatics unit which does a lot, which includes epidemiology, but more than just that does a lot of work with the various piles of data that we have and making sense out of those as well. So, we have programs like cancer programs, like trauma registry, like, various different things like that all could use, that would be well informed by a medically trained person.
Right. We have just about 4 minutes left, and I'm going to ask each of our panelists a final question and ask you to be very brief. What do you like most about your job? What do you like most about being a health officer? And I'm gonna start alphabetically. I'm going to go, Bert, I'm going to go with you first.
I think the most important part of being a health officer is making a difference. There are opportunities to improve the health of individuals in the community on every single corner of every single intersection. And public health is the vehicle that can make a difference. And right. If we don't deal with population health, we're going to continue to have significant disparities in health. And it's an opportunity to educate, provide direct patient care, and really make a difference in the community.
Great. Thank you, Bert. Scott?
I guess just, my own belief is the only reason we're here on earth is to take care of other people. And that's true whether you're a physician or something completely unrelated to that. I really like that my job lets me do that. It's very rewarding, and even better, it lets me work in an organization where almost everybody else seems to feel the same way I do about that. And that's really special.
Very special indeed. Thank you, Scott. David?
Basically, the variety, if, you know, we have so many varying interests, and when you're in the field of public health, I mean, we have interactions with law enforcement and fire. You know, Dr. Harris talked about EMS, and you have primary care clinics, and you have, you know, hospital systems and nursing homes, but then you have, you know, grassroots organizations. So there's so many things that you could do. When we walk in every day, we don't know what is going to hit, and it's a wonderful, crazy thing to have to and privilege to be a part of that. So it's just the variety where you can use all parts of your skill set and your brain and other parts that you didn't know you had to make a difference.
That was certainly my experience, David. Thank you so much for that. Dr. Mack?
Well, growing up in a multi-generational family, one of the things I learned was that it's not just about me. That we have to make sure that we're considering at all times other people. And that's what I like about this, actually knowing, even though sometimes it gets really tough and it's rough, okay, that you can actually look and say that, yes, I made a difference and we made a difference. And that's what's important about this.
Thank you so much. Mark, we have less than a minute. It's yours.
I love the impact, and I also, as others have mentioned, love the variety. It's never, there's a whole plethora of subjects that you can be involved with in a given day.
Great. Wow, what a great group of folks to have on this panel. Thank you all so much. We will post this recording and post the information about contacts on our School of Public Health website. So thank you all to our participants for joining us, to all our panelists. Thank you so much.